yeah, thank you very much, Dr. Khanna, for this opportunity, and respected chairpersons for this kind introduction. So today, the topic that has been allotted to me is nutrition in the elderly with renal disease. So as we realize that this is a part of the special population, because just as Dr. Iyengar before me was given the topic of nutrition in children, similarly, I have been given this topic, nutrition in the elderly, thus re-emphasizing the fact that there is something special about nutrition in the geriatric population. The first thing that we need to realize is that old age, or the geriatric population by itself, without underlying kidney disease, is prone to malnutrition. And the fact that they also have kidney disease kind of makes them more prone to malnutrition. And the major nutritional problem that is associated with them is weight loss, which is associated with the protein energy wasting that they have. Now, if we compare the elderly who have renal disease and the incidence of protein energy wasting in them, it's as high as 50 to 68% as compared to the younger population, the population who's not the geriatric age. Of course, it excludes the pediatric population, but where it is around 25 to 50%. And the bottom line is that we are so worried about this whole concept of malnutrition in patients with renal diseases, because it increases the mortality as well as the morbidity and the quality of life in these patients significantly. Before I actually speak about nutrition, we really need to understand who's the true elderly renal patient. So at the back of our mind, we need to remember that EGFR alone is not a representative of renal function impairment in the elderly, for the simple reason is that they may have renal structural changes or a subclinical vascular disease, which we may not be able to discriminate amongst the aging, so which could be a part of normal aging, as the normal GFR drops with aging, irrespective of a renal disease. So we need to really question ourselves before we label them as renal patients. And EGFR should not be taken as the only representation of an underlying renal disease before we start, flooding them with interventions to delay the progression of CKD. Because there is a very large part of sarcopenia and just underlying malnutrition in the elderly, which is present in these class of patients, and which may influence the GFR to a very large extent. So before we actually label a patient, an elderly patient, as a renal patient, we need to be very sure that he is a renal patient. Now, what are the common causes of malnutrition in the elderly? So these reasons would be common in those who have a renal disorder and those who don't. So there are medical causes like the senile atrophic gastritis. They have dentition, swallowing problems. They have an underlying cardiac insufficiency, which may give rise to early satiety and not proper nutrition. There are a lot of mental health problems associated with old age, like depression, living alone, inability to carry out their activities of daily living because of physical or mental illness, or an underlying dementia, which may be very slow growing and not picked up. Of course, with age come other maladies, and there is a very large extent polypharmacy, which also can affect the appetite and nutrition in these patients. Now, what are the causes of weight loss? So all of these risk factors essentially do cause weight loss and the protein energy malnutrition wasting in these patients. And the most common causes are cachexia, that is essentially any chronic illness can lead to wasting, to anorexia, that is they have a loss of appetite and a disinterest in food. Sarcopenia, which is the loss of lean muscle mass, and we are going to have a dedicated lecture for this, and I'm not really going to waste too much of time talking on sarcopenia. And of course, dehydration, because the elderly patient is always more prone to dehydration and water metabolism imbalance because of age and the physiology related to it. So as I said, all of these problems together, the age-related problems, the psychosocial and the medical problems, and basically the CKD-related problems like uremic toxicity, the metabolic derangements, the inflammation which is associated with CKD, leads, the consequences that come down to is a worse quality of life, increasing sarcopenia, frailty, and eventually leading to mortality. Now, when you have an elderly patient with an proven underlying disease, how do you assess the nutritional status of this patient apart from the normal anthropometric measures, which we have been hearing over and over again all this time, and probably a lot more detail in these conferences? We can look at the biochemical indices like serum albumin, or if you have the measure pre-albumin. So an albumin level of less than 3.8 grams per liter, or an iron binding capacity of less than 250 milligrams per deciliter, does point towards a impaired nutritional status in the elderly. If we have to look at the whole body assessment, you can look for a BMI, which is less than 22 kilograms per meter square, or the history of a significant weight loss, which is defined as a less than 5%, 5% weight loss over the last 3 months in case the patient has an acute kidney injury or an acute renal disease, or more than 10% of the baseline if we are looking at CKD. Now for CKD, it's independent of time, whereas for AKI, we do keep a 3-month time period because that's when they have been maximally sick. You can also go for body composition where if there is a decreased fat-free mass, so which is defined as less than 15 kilos per meter square for women and less than 17 kilos per meter square in men. Or look for sarcopenia, that is a skeletal muscle index of less than 6.75 kilograms per meter square in women and less than 10.75 kg per meter square in men. We can also look for the historical symptoms like persistent anorexia, nausea, vomiting, failure to thrive, and diarrhea, which last almost daily for at least a period of 3 weeks. And lastly, you can actually sit down with your dietitian and calculate the dietary intake. So we define the decreased energy intake as an unintentional low dietary energy intake, which accounts to less than 25 kilocalories per kg per day for at least 2 months. And similarly for protein, it's a low dietary protein of less than 0.8 grams per kg per day for at least 2 months for patients who are with dialysis, or those who are on non-dialysis CKDs of less than 0.6 grams per kg per day. So here is the role of the dietitian is because they are going to have a recall and a diet diary, and that's when we are going to be able to calculate their daily dietary intake. Now, the nutritional treatment in elderly non-dialysis renal patients, why is it important is that the transition of these patients towards dialysis, so patients who are CKD stage 2 to 5 non-dialysis, they are going to eventually, the transition is going to happen towards dialysis. And this becomes extremely critical in elder patients because of a few reasons which are specific for this population. The reason being, one, we have to realize that patients of CKD who are elderly have a functional capacity which is much lower as compared to the younger generation, even before the start of dialysis. And usually studies have said that there's a steep decline in the few months just before dialysis and 1 year after dialysis. So it's only 13% of patients are able to maintain their pre-dialysis functional status. So this is something that we have to aim for with the nutritional treatment, that the patient maintains his functional status even before and even after initiation of dialysis. And that is why they require the special health care, including the nutritional care, so that their frailty doesn't increase and their quality of life remains as it was before or maybe improves. And you let them have the physical as well as the emotional independence that they had before the onset of this illness. So we obviously have the most common approach that we have is the conservative approach, which is the low protein diet, that's the LPD. Now the advantages are that it definitely lowers the CKD progression. There is no two ways about it. We have enough of data which shows that. And it also improves uremic toxicity along with improving the other risk factors that usually cohabit in the patient with CKD. So, the metabolic acidosis and the hyperparathyroidism, the hypertension, the proteinuria. So all of this is better controlled. But in our patients, in the elderly, you have to also focus on the disadvantages that it is associated with the low energy intake, which is inadvertent. It results in a negative nitrogen balance with an impaired glucose homeostasis because these patients are taking a low energy intake, they're taking low carbs, and so there is an impaired gluconeogenesis, especially important in our patients who are elderly and diabetic because they get more and more prone to hypoglycemia and of course ultimately to protein energy wasting. So the recommended dietary allowance, as we all know for proteins, is, to ensure that the metabolic requirements are carried out, is 0.8 grams per kg per day. Now, irrespective of renal disease, the protein intake inadvertently with advancing age keeps falling down, but it rarely goes beneath 1 gram per kg per day if the patient is having a standard, a well-balanced meal. Now, in contrast, it's very easy for the energy intake to go down in the elderly CKD patients. So there may be a progressive reduction to around 25 kilocalories per kilo of body weight, which is not acceptable. So as I said, that with age, inadvertent decrease in proteins do take place, but it rarely goes below 1 gram per kg per day, which is very acceptable, because in kidney disease, we anyway define it as 0.8 grams per kg per day, but we have to focus on the fact that the energy requirements come down much more drastically, and they can fall to as less as 20 to 25 kilocalories per kg per day. The end result of this is that the patient goes into a negative nitrogen balance. So there is something that is called as safe nutritional intervention in elderly CKD patients, where before you actually start restricting proteins for them, you ensure that they get a high energy meal to preserve their nutritional status. And when I say high energy, I mean 30 to 35 kilocalories per kg per day is what is necessary for them to preserve their nutritional status. Once we reach that, then the low protein diet comes into play, where you can give up to 0.6 grams per kg per day with the essential amino acid supplements and the keto acids, or a 0.8 grams per kg per day. And there should obviously be no accompanying metabolic acidosis or hypercatabolism in these patients. Along with this, you ensure a poor salt diet, but not a salt-free diet, because these patients are extremely prone to hyponatremia because of age and the physiological changes, also because of the CKD, and also because of the accompanying drugs that they may be taking at this point of time. And we also need to ensure that these patients have their daily dose of minerals and vitamins, because again, there is a tendency for these deficiencies to develop with old age. So we can promote diets which are rich in fruits and vegetables, like the Mediterranean diet, which may not be actually possible in the Indian setting, but something as close to that, which is very rich in fruits and vegetables. Now, we are going to have a dedicated talk on plant and animal-based diets in this conference, so I'm not going to really elaborate on that. But the bottom line is that, yes, we need to have a diet which is rich in fruits as well as vegetables. Now, there is a unique concept called the combination strategy or the combination intervention, where we combine a nutritional intervention along with a low dose of dialysis. Now, we all know that starting off dialysis at any age is definitely going to prolong the survival, but especially in the elderly, there is definitely a reduction in the quality of life. It lowers the functional status, because this patient then becomes dependent on dialysis 3 times a week, 4 times a week. They have to go to the dialysis unit, and it also, affects the interpersonal relationships, their social life, and it may also have an impact on the financial status, given to consider that, yes, we come from a low resource setting country. So these are things which specifically need to be looked after in the elderly. So what we can along with that, starting the dialysis itself, and CKD by itself may, make these patients suffer from something that's called as the MIA or the MIA syndrome, which includes malnutrition, inflammation, and accelerated atherosclerosis. So a strategy which can help to solve both these dilemmas, that is, you give them a good quality of life and relieve them of the uremic toxins, both of it together can be achieved by combination of nutritional intervention along with a low dose of dialysis. So the integrated program, which can be used in these patients, is a very low protein diet, that's around 0.3 to 0.4 grams of proteins per day, supplemented with a mixture of essential amino acids and keto acids for 6 days a week. You give them a strict sodium and water restriction, and you give them 1 or 2 hemodialysis sessions per week with an unrestricted diet on the dialysis day. Now, an ideal case scenario would be that the patient is offered a low dose peritoneal dialysis, which is a lot more physiological, less invasive, can be a home based therapy, and much better tolerated in these patients who may have a higher incidence of underlying cardiovascular disease. Now, whereas the combination strategy sounds very good theoretically, to a large extent in our country, it may not be possible, because this requires a very close follow-up with your clinician and your dietitian. And knowing the Indian mindset, essentially, that once they start feeling better, the follow-ups become delayed, and obviously the fact that these are not insurance policy covered strategies, the financial issues also become a point. They are not very commonly used in our country, but yes, there is enough data that says that they can be successfully used, especially in the elderly. Now, the advantages of this are that, yes, on one side, the metabolic components, clinical symptoms of volume overload, and you maintain your residual renal function, and obviously the patient is more functional emotionally, more functional physically. He doesn't have to keep visiting the hospitals, and to a very large extent, there is a lot of dignity in which is preserved, and obviously the direct, indirect, the financial aspects of what I spoke is it works out better. But as I said, the concerns are that it requires a very strict therapeutic regimen with, and the diet becomes very unpalatable to a very large extent. And these are the patients who may, kind of tip over to malnutrition, and therefore requires a very strict monitoring with a multidisciplinary team with a dedicated renal dietitian. And it may also require the help of the family and the caregivers who are going to take responsibility of the entire strategy, which may be difficult on some occasions. Now, what are the nutritional interventions which can be done? So the basic aim of the nutritional intervention would be that you tackle the age-related causes, you tackle the psychosocial and the medical issues that are associated with these patients, and you counteract the dialysis-related, the specific dialysis-related problems that would come, like the uremic toxicity or the metabolic derangements, and the, as I said, the MIA syndrome. So you tackle those also, so that you kind of intervene for the acute and the chronic long-term complications that these patients would specifically have. So if we say that we have the intervention of the age-related, so as I said, the common age-related, like the chewing, the swallowing, they have atrophic gastritis, they may have malabsorptions. So there have been a lot of studies which say that we can add the oral nutritional supplements to the regular diet, and beta-hydroxyl beta-methyl butyrate is the most commonly studied supplement as of now. And of course, we make sure that they have their vitamin D supplements, their calcium supplements, and a very dedicated team of physiotherapy and rehabilitation for these patients, especially during the time of dialysis, would help in tackling the age-related problems like sarcopenia or the protein energy wasting that is seen with age. Now, we have to remember that all of these are being extrapolated from the data which is given to us for elderly patients with non-renal diseases. We do not at present have specified trials or protocols or robust data that is going to help us for these interventions in patients with renal diseases. And this is the need of the time right now. The various psychosocial and medical causes, the medical treatment of dementia and depression, and the psychiatrist needs to be involved. There is a large body of data which says that homocysteine supplements in these patients help them overcome a lot of psychosocial issues. There are large trials which say that socialization and group therapy, so eating together and not allowing them to eat alone or with friends, or eating in the dialysis centers or eating with other patients or with the family, does increase their oral intake significantly. And there are a lot of modifiable risk factors for cognitive decline which need to be worked with. And this is where you would require the help of a psychiatrist or the psychological counseling in these patients. The interventions related to the dialysis related causes. So, you try giving them a snack during dialysis, because then you are sure that they have eaten whatever they were supposed to, or their nutritional requirements have been met with in a directly observed way. And we may also add the oral nutritional supplements during dialysis, so provided during the session. So again, you're ensuring that you have it. And there is a large body of work which says that especially for the frail and especially for those who have the protein energy wasting, intradialytic parenteral nutrition intermittently will help them to get over, because we need to remember a well-fed or a nourished, or maybe to a large extent, I may use the word obese patient on dialysis does significantly well as compared to a malnourished or a frail patient on dialysis. And there is enough data today to suggest that these patients do worse as compared to a obese patient. So essentially, I'm going to end my talk with the next few messages, which will be my take-home messages, that we need to realize that elderly patients, irrespective of their renal status, are more frail, and with the renal disease are at a higher risk of impaired nutritional status. We need to have a regular monitoring for their nutritional status, including their nutritional intake, the risk factors which are associated with aging and kidney disease, so that we discover these nutritional impairment early and we can intervene at the right time. We need a multifaceted approach, and it can't be just a dialysis technician or just a dialysis nurse or just a nephrologist looking after this, because we have many factors that need to be looked after apart from just diagnosing the protein energy wasting. So including managing the food preparation, the cognitive dysfunction associated, the depression, and the social integration in these patients. We may try and use the safe strategy. We don't have a choice here. So we have to include and ensure that the patient has a high energy intake, a 30 to 35 kilocalories per kg per day intake, before we actually initiate the dietary restrictions of protein, salt, and other micronutrients like phosphorus, because a patient who does not have this will eventually lead to negative nitrogen balance and severe protein energy wasting. Lastly, combination therapy, that is nutritional intervention with low-dose dialysis, is a novel therapy for the elderly, which has to be thought about and practiced, obviously with a multi-team approach. So I end my talk here, and I'll be happy to take any questions.